The following is a conversation with Jordan Haworth, a gut health physiologist working at the Functional Gut Clinic who are based in Manchester and London. In this conversation, we covered possibly the widest range of gut health related topics in the history of Inside Matters. So this could become a reference episode for all things gut health in the future. Jordan is a fountain of knowledge relating to basically all things to do with the gastrointestinal tract, prebiotics, probiotics, polyphenols, everything. We covered what to eat for your microbiome, what not to eat for your microbiome, what IBS is, including how to potentially classify it in a way that's not currently widely accepted amongst the broad range of medical community specialists that currently focus on IBS. We talked about antibiotics, in particular an antibiotic called rifaximin, which counterintuitively may actually be good for gut health in specific situations. We also talked about food sweeteners, emulsifiers, and some of the really exciting research that Jordan and the team at the Functional Gut Clinic are focused on. I absolutely loved this episode. I've learned a heck of a lot. I'm absolutely sure you will as well. This is Inside Matters. My name is Dr. James McElroy. I hope you enjoy it. What are you most excited about in that sort of full spectrum context, full spectrum in IBS?
In IBS, so IBS has traditionally been thought as it was a functional GI disorder, but now it's been relabeled as a disorder of gut-brain interaction, right? So is it this communication between the gut and the brain? And traditionally, it was also thought to be more of a psychological problem, right? In a certain subpopulation of females, but we know now that actually IBS affects a lot of people, around 1 in 10, right? And it's actually a very heterogeneous disorder, so there's many different potential causes of irritable bowel syndrome. It can be related to the microbiome, can be related to food intolerances, an immune disorder. So it's really, because it's so heterogeneous, we're not sure what direction, treatments are going. But I'm really excited about sort of the microbiome related therapeutics, right? So at the minute, there's a lot of evidence for probiotics in IBS that they can potentially be helpful. And then other microbiome therapeutics, right? Like FMT is what we're going to be looking at.
Absolutely.
So yeah, I think IBS it was always considered a lifelong condition, right? A chronic condition. But I think that there will be at some point in the near future almost a cure for IBS. And one way we can see that already is that there's 3 different subtypes of IBS, right? There's 4, but the 3 main ones are IBS-D, which is diarrhea predominant irritable bowel syndrome. There's IBS-C, which is constipation predominant irritable bowel syndrome, and then there's IBS-M, which is where you have a mix of diarrhea and constipation. The 4th one is IBS-U, which is unclassified. You don't have either, but that's probably more.
And in that U, so what kind of symptoms do patients have in the U? It's like bloating and...
So exactly. So you meet the criteria for IBS in terms of abdominal pain. So that is the defining symptom of irritable bowel syndrome, abdominal pain. In fact, bloating isn't even considered a symptom for the diagnosis of IBS, which I think is ludicrous.
Really?
Yeah, it's ludicrous because when you actually ask patients with IBS what the most bothersome symptom is, it's bloating. But IBS is diagnosed by a criteria called the Rome criteria, and bloating isn't a factor in that diagnostic criteria. So it's abdominal pain, and then it's based on your bowel habit, right? So IBS-U is you don't actually have any changes to the bowel habit, it's just the abdominal pain.
Any idea why it's not part of the Rome criteria if it's so prevalent?
It's a very good question. I'm hoping that in the next iteration it's introduced. So they are discussing Rome, so it's Rome 5 next. So I'm hoping that it will be introduced then. But what we know is that there's been a lot of, with IBS-D, there's a lot of actual organic causes of IBS-D. So there's a recent meta-analysis which actually looked at potential organic diagnoses in patients with irritable bowel syndrome. So with IBS-D, we have bile acid malabsorption, which seems to affect around up to 40%
Wow.
of patients with irritable bowel diarrhea predominant irritable bowel syndrome have some degree of bile acid malabsorption. There's pancreatic insufficiency, which is a little bit less common. It seems to affect around 5% of people with IBSD. There's lactose intolerance, which is an intolerance to the sugar found in dairy. And then there's this small intestinal bacterial overgrowth, or SIBO, which again seems to affect around 1 in 3 people with IBS. So SIBO...
Is that IBSD or all IBS?
All IBS. It's more so IBSD, but depending on the kind of gas that the bacteria produce in SIBO, so for those who are unfamiliar with SIBO, right? SIBO stands for small intestinal bacterial overgrowth. It's a condition where there are basically too many bacteria in the small intestine. So the small bowel should be relatively low in bacteria. In fact, the duodenum contains around 10 to the power of 3 bacterial cells per milliliter. So if you used to take a milliliter of juice from the duodenum and culture it onto a plate, you'd expect to see around 1,000 bacteria there, right?
Right.
When you compare this to the colon,
Right.
which has about 10 to the power of 11, so that's 100 billion bacterial cells per milliliter. It's a huge difference, right? So with SIBO, what happens is you get this overgrowth of bacteria in the small intestine, and the small intestine is responsible for absorption of nutrients. So if we have too many bacteria there, what they do is they begin to ferment and break down our food. Specifically, carbohydrates is their preferred fuel source. So they begin to ferment this food before we have the chance to digest it. And then in doing so, they produce gases, right? So the main symptom of SIBO is bloating. And this is why we think a lot of people with irritable bowel syndrome have bloating, because they have this overgrowth of bacteria in the small bowel. And depending on the type of gas that they produce, so we just alluded to this, so if they produce hydrogen sulfide gas, the bacteria, if you've got sulfate-reducing bacteria, that's associated with diarrhea. Or if they're not actually bacteria, but archaea, these are slightly different microorganisms. They produce methane.
Ancient.
Yes, exactly. It's the clues in the name, right? They're actually the oldest microorganisms to exist. Yeah. So we actually think we evolved from them at some point.
That's pretty mad, isn't it?
It's pretty. So like 4.5 billion years ago, we were one of these cells, right? And now they're living in our gut.
We're talking about them now. It's mad.
It's cool. Yeah. So they produce methane, and methane is associated with constipation, so IBS-C. So we can diagnose this SIBO quite easily, right, with a hydrogen or methane breath test. So traditionally, the gold standard was thought to be actually taking a sample of bacteria from the small bowel, but there's a lot of issues with this. It's super invasive, right? Imagine
how do you do that?
Yeah, so during an endoscopy, an upper endoscopy, they will actually take a sample, pull it out, culture it. There's a few issues with that. The first is 1 in 5 of those samples are contaminated as you pull it back through the gut from bacteria in the stomach and the esophagus and the mouth.
Because as we were speaking about before, there's a microbiome in the mouth. There's a microbiome in the esophagus.
Yeah.
Well, there's a microbiome everywhere, right?
Right, yeah. So,
but the contamination thing makes sense.
Yeah, and obviously it's difficult to grow, to culture certain bacteria. So
absolutely.
Methanogens, the ones that produce methane, these archaea, are pretty impossible to grow because they're anaerobic. So that's another issue. So we have these hydrogen and methane breath tests, which work by basically you ingest a sugar probe, which is usually lactulose or glucose. When that sugar hits the small bowel, if there's an overgrowth of bacteria there, what they'll do is ferment that sugar. They'll produce these gases. These gases are absorbed from the gut. They're transferred from the blood to the lungs and excreted in breath. So we measure those gases. It's not a perfect test, but it predicts response to treatment. So a positive lactulose breath test predicts your response to antibiotic therapy for SIBO.
Okay.
And the preferred antibiotic is something called rifaximin, which is a non-adsorbable antibiotic. I know a lot of people are scared of taking antibiotics because it can be detrimental to the microbiome, not just in the gut, but as we just spoke about, on the skin and everywhere else. But rifaximin is really cool because it's a non-adsorbable antibiotic. So it's not absorbed into your bloodstream. It doesn't affect any microbiome on your skin or elsewhere. It actually works really well in the small bowel because it's activated by bile. So when the drug mixes with the bile, it becomes really potent.
And for the listener, the bile is something produced in the liver and it comes into the upper part of the small intestine helps you digest fats, right?
Yeah. Yeah.
So it's activated by something which is produced in the upper GI tract, therefore it comes to life where you want it to come to life.
Exactly. And by the time it's reached the colon, it's actually less effective, so it doesn't affect the colonic microbiome, which is where most of our gut microbiome resides.
Very interesting.
It's actually been shown to be a eubiotic, which is a kind of a phrase that most people might not be familiar with, but if we think of like a prebiotic that feeds the good bacteria, probiotics are the good bacteria. A eubiotic is something that kind of restores the balance of the bacteria. So rifaximin, really effective, really safe compared to other antibiotics. And so in people with SIBO, they take a 2-week course of this, and around 70% of them, they will eradicate that SIBO, and then their IBS has pretty much disappeared, right?
So I went through 7 years of medical training to become a doctor. And I cast my mind back to the lectures we had on IBS and the discussions we had about IBS. It's a diagnosis of exclusion, they would say. And you've got these 3 different types, and basically you try dietary manipulation in a lot of patients, and we should get to that. And afterwards, if that's not working, you should just refer to a specialist. But what's fascinating, just listening to you, is has the medical community kind of maybe got this wrong a little bit? You know, because what the classical medical approach to IBS would be is it's a diagnosis of exclusion, which suggests that it's not really a real thing, right? And patients come in, the clinician goes, yeah, you've got IBS, okay, off you go. But they don't say why you've got IBS.
Yeah.
Whereas you're drilling into now why they've got IBS. It's that small bowel, small intestine bacteria, not small bowel, the small intestine bacterial overgrowth. You've talked about the post-infectious. You've talked about the archaea producing the methane. You're sort of building this web, if you like, or this tree of, to bring it right back to what you said at the start, organic causes for different types of pathology. So do you think then that over the next few years we might even start to move away from IBS into defined subgroups as completely different things?
I would like to think so.
Right.
But I don't think it will. Is
that because the good and the great are?
Yeah, I think it's quite political, so I won't get into that. But yeah,
fair enough.
You know, we've got these organic causes: SIBO, bile acid malabsorption. You can even treat that empirically with something like cholesevelam, and we see that a massive improvement. Almost again, the IBS is resolved. Pancreatic insufficiency, you give them the digestive enzymes, and the IBS is almost resolved. So, yeah, I think there is a bit of it's misleading saying it is a disease for life, right? Because I think there are ways that at least we can manage it and control it so that your life isn't plagued by this disorder.
I'm going to, in a second, bring us back and go high level again and talk about how you got into the field and so on. But I just wanted to press a little bit on the FMT element. So you're an expert in IBS. You're working with a group of people who are experts in IBS. How do you see FMT fitting into this whole thing? And maybe you can bring it to the post-infectious patients, the methane producers.
Yeah. So at the minute, the studies of IBS the studies of FMT and IBS, are quite, you know, it doesn't seem like it's quite
mixed
there,
evidence.
Right? It's mixed. Yeah. So again, because IBS is such a heterogeneous disorder, are these studies ruling out things like bile acid malabsorption and pancreatic insufficiency before they do the trial? That's one thing I'd like to know. And then what we have seen at least from a couple of recent studies is that there is actually a subgroup of patients within these trials that benefit, and it seems to be the ones that do have some sort of dysbiosis or imbalance in the gut microbiota in the first place, right? So one study looked at FMT in a group with IBS-D, so diarrhea predominant irritable bowel syndrome, and found that actually overall it wasn't statistically significant FMT, but in a subgroup of patients who had an overgrowth of hydrogen sulfide producing bacteria, they actually saw a benefit in symptoms like bloating. So that begs the question, maybe if we can identify this subpopulation of people with IBS who have dysbiosis or some sort of imbalance in the microbiota, could they be the ones that are more likely to benefit from FMT, right? So I think that's the direction that it needs to go.
And what's your thoughts on the design of the trial? Does it need to be placebo-controlled?
Yeah, that's another good question. I think ideally,
Yeah.
placebo-controlled trial. Especially with IBS, you get this naturally high placebo response rate. So out of many different disorders, IBS has, I think, around 30-40% of people
40%,
taking placebo will feel some sort of benefit. So I think it's really important to have that, but also really important to look at other outcomes than symptoms. So looking at the microbiome, like this subgroup with hydrogen sulfide or methanogens, so methane producers, I think that's really important.
Could we just tease out maybe why there might be a high placebo response rate? Because when we started talking, you talked about it used to be classified as a psychological, psychiatric type syndrome, symptomatology. Is there potentially an element to do with the brain communicating with the gut, do you think?
So definitely. I think there is with most GI conditions, so not just IBS, but like functional dyspepsia, even constipation and diarrhea to some extent. There's a huge psychological component. We know this as, like, personally, when I get really nervous, I need to go to the toilet, right? Yeah. So before.
Why is that?
So I think it's just a release of different neurotransmitters. And so we think the gut and the brain, because they're so closely linked, right? And there's a lot of neurotransmitters in the gut that are also in the brain, but they have different roles in the gut than to the brain, right? So serotonin is the one that I always use as an example. Serotonin produced in the central nervous system is important for mood. It's important for sleep. It's important for arousal. It has lots of different roles, right? But in the gut, it has many other different roles. So it is involved in motility, so how the gut contracts. It's involved in secretions, so what's brought into the gut. So if you think you're getting a release of these neurotransmitters which are causing your bowel to contract more quickly, or more secretions, which means it's a lot easier for stool to pass through. I think that's probably where the sort of the gut-brain connection comes in, right? And don't get me wrong, I do find a subgroup of patients with irritable bowel syndrome that benefit from these neuromodulator treatments, right? So these are treatments that target the neurotransmitters. So there's a bit of stigma around them because they're antidepressants. Yeah. But we're not using them to treat depression, right? We're using them to treat the gut, as I've just alluded to. If you take a selective serotonin inhibitor, it's because serotonin in the gut has those roles on motility and secretion. So we're targeting that. We're not necessarily targeting, mood and stuff. But, if you do have some anxiety, some depression, because your stomach issues are getting you down, there might be a mutual benefit there, right? So there's definitely a subgroup of patients with irritable bowel syndrome that benefit from those treatments. But yeah, the gut-brain connection is strong, and even people like myself without a GI disorder experiences it. So
the butterflies in your stomach.
Butterflies, yeah.
Now, just one quick question, then I'm going to bring us back to some bigger questions. So, can you explain why coffee makes you run to the loo?
So we think that it's mostly related to the caffeine in coffee, because you get this increase in motility. That's what kind of the animal studies show. We don't really have any human studies to prove that, but based on animal models, it seems that it increases motility in the gut. But what's interesting about coffee is it actually has many gut health benefits, right? Because it's full of these polyphenols, which are these antioxidants that promote the growth of good bacteria, and also have benefits on things like heart health and other systems throughout the body. So you can actually get the benefits of those polyphenols from things like decaf coffee.
Without needing to run to the loo.
Yeah.
So to bring us back then, big open-ended question. What is gut health?
That is a very interesting question. I would say gut health, to me, is being able to enjoy foods, pretty much any food that you like, without having to worry about experiencing symptoms afterwards. So to achieve that is quite difficult. I've been really lucky because we actually make a joke about this, right? So I used to eat a lot
I know the joke.
Yeah.
But I'm in the know, so tell the listeners the joke, yeah.
So I used to eat an absurd amount of fruit and vegetables, right? Like, I was vegan for a while.
Right.
I went raw vegan for a while. Don't ask, that's a story for another day.
What is raw vegan?
So raw vegan...
Is this the next level?
Raw vegan is where you would only eat fruits and vegetables. This was, I was in my early 20s. I was sort of brainwashed by people on Instagram and YouTube who were living in like the tropics, and they were saying this is the right way to eat. Because of all this fruit in abundance, it's meant for humans. Blah, blah. Anyway, I went down the rabbit hole. I tried raw vegan for a while, and I was eating like whole watermelons, and people with IBS are probably curling their toes at hearing that, because it's full of fructose, right? And even a sliver of watermelon is going to give them the worst bloating and the worst tummy pain. So my gut microbiome must have been pretty like... Yeah. So we made a joke saying that, we should preserve I'd be a perfect stool donor. And my boss was like, you can't go on holiday to anywhere where you could get like traveller's diarrhea or gut infection.
Well, I think, as you know, my company's in the business of finding stool donors, so maybe we could have a discussion about that.
Maybe, yeah, but my diet now is just is like over Christmas. I've enjoyed myself, I've indulged, and look, fortunately, I still don't get any stomach issues. But yeah, gut health it's a difficult question to answer, but that would be my answer. Being able to enjoy what you want to eat without hurting afterwards.
Perhaps it's easier to frame it in the context of what isn't healthy. So what symptoms and signs would people be experiencing that kind of isn't normal? Yeah,
so going back to bloating, I think bloating is probably the thing that people report the most, but bloating's actually non-specific to the gut, right? So if you're a female, you can be bloated around your menstrual cycle. Yeah. I think we could all feel bloated if it's Christmas, we've overindulged. But bloating to be abnormal, I would say you're experiencing it several times per week or daily. It's uncomfortable. Usually your stomach is distended. So what a lot of people will say is, I'm bloated. But bloating is actually a feeling, right? When your stomach protrudes, so you almost look pregnant or you've swallowed a balloon, that's actually called distension. But we don't say I'm distended because that just sounds a bit silly, right? You wouldn't say that. So I would say if you're experiencing things like bloating or abdominal pain, so pain at least, again, several times per week or daily, and then if your bowel habit is another tricky one to discern whether it's healthy or not, because it's quite a wide range of what's considered normal. So it could be going once every 3 days to 3 times per day. Just normal.
Still normal?
Yeah. As long as it's what you do routinely, right? But when your bowel habit changes suddenly, so you're suddenly going more or you're suddenly going less, that's when that isn't healthy, and that's probably when you should be going getting checked out, right?
When people come to you for gut health advice, what is the most common symptom that they're experiencing?
I'd say it's bloating for me, yeah. Bloating is what most people report. In our clinic, we see a lot of like heartburn and acid reflux as well. But what we find is that usually people have more than one symptom, right? It's not just bloating, it's not just acid reflux. It's a host of different symptoms, yeah.
But actually, how did you get interested in gut health?
Good question. I kind of fell into gut health, right? I'm a gastrointestinal physiologist. Physiologists are a group of scientists that study different physiological systems. So you can have a cardiac physiologist, they look at the heart, respiratory, exercise, sleep. But I'm a gastrointestinal physiologist. I also sometimes call it a gut health scientist because it's quite a mouthful to say, right? And traditionally in the UK, there's one route to become a physiologist, and it's called the Scientist Training Programme, or the STP. Right. It's ran through the NHS. It's a 3-year postgraduate scheme for people from biomedical and life sciences. You get paid a band 6, which is pretty good, coming straight out of uni. And you also get a master's degree at the end of that. But I'd actually applied for immunology because I was super interested in the immune system and autoimmune disease. Right. And this immunotherapy. So I'd done a review as part of my clinical immunology module, where it was called CAR T therapy, which is basically where you take someone's immune system cells, you tweak them and to target the cancer, and you put it back into them. I thought that was really cool and where the future's going.
It's so cool.
Yeah.
Someone described them to me as robo-cops. They're tooled up, they're armed up, and they go hunt down the cancer. It's amazing, right?
Yeah, it's so cool. And I thought this is where the future's at. I didn't get on to the immunology STP. I think it was really competitive and there was only a few places. And I did well at uni, but I didn't have any experience to set me apart. So I thought, I'll do a master's at my uni and I'll reapply for the STP next year. Anyway, about 3 days after I did my final exam, I saw this job advertised, 3-year training, sounded just like the STP but in GI physiology. It was in Manchester. So I went, I met Professor Anthony Hobson, who is the clinical director of Functional Gut Clinic, and they were sponsoring 2 positions on this alternative route to the STP, which had just been introduced by the Association of GI Physiologists, AGIP, which are part of the BSG, so the British Society of Gastroenterology. So there was 2 positions. They were given to 2 of my colleagues, but Anthony opened up a 3rd position for me because he said I was so passionate about the research that I'd done and the research that I wanted to do. And I think that's kind of why I'm so passionate about translating gut health information now. I'm looking at the research. But I'm so glad because gut health is the most exciting area to be researching, right?
Absolutely.
Yeah. And going back to my interest in the immune system, we now know that something like 70% of the immune system and immune cells reside in the gut. And it's linked, so the gut microbiome in particular is linked to autoimmune disease. And then going back to immunotherapy, what they're basically doing is people who aren't responding to this immunotherapy, they're taking the microbiome from the patients that do, giving it to those who didn't respond, and it's actually improving their response to successive treatments. So I think that's just so cool.
And some of the response improvement is like insane. So for the listener, when they're doing these studies, they can classify response through a number of sort of objective classification tools. So some people don't respond at all. Some people have a partial response. Some people have a complete response. And what they've shown is that in a percentage of patients who have no response at all, they can flip them into a complete responder.
Wow.
That's mad, isn't it?
That is crazy.
Just by changing the microbiome. So maybe, one of the things we don't understand about immunotherapy is why does it only work in 40% of the patients? And in those 40%, why is there a spread? Right? Because they've got the same tumour. So some of the thinking at the moment is perhaps it's the gut microbiome, which has an impact perhaps on the tumour microbiome, which is another discussion, that's driving response in these patients. And that's really exciting because we could change the microbiome in all of these patients through antibiotics, prebiotics, polyphenols, probiotics, FMT, all the things we're going to discuss in great detail on this podcast. If you listen back to all the episodes, whenever I ask about at-home microbiome tests, they either put their head back in the chair like this, or they burst out laughing, or they sometimes throw their hands up in the air, because it's like, some people are making a lot of money from this.
Yeah.
Right?
Yeah.
And I'm not sure, having asked lots of people, and I'm going to ask you right now. Actually, I won't get in the way of what you're going to say. Let's go back to your role as a physiologist then. So, what are some of the most exciting things in the field that you're aware of at the moment? And how's things changed since you first got interested in gut health to where we are today?
So I started around 6 years ago, and as a GI physiologist at least, the most, I wouldn't say exciting area, but the area where there was most investment and interest was gastroesophageal reflux. So looking at basically acid reflux, and that was that. But around 6 years ago was about when the microbiome stuff was taking off, right? And that's what I took a huge interest in. And we did a little bit of microbiome related stuff in SIBO, so the small intestinal bacterial overgrowth testing. It's not quite looking at the microbiome in detail, but it's kind of an indirect marker of dysbiosis.
It must be, right? I mean, is it not just that's a microbiome problem, in effect?
Exactly, yeah.
What does the future look like then for someone working in this field? You mentioned the microbiome has really come to fore, and we talked about SIBO there being a microbiome disease. What's next?
Well, what I was going to get onto is that with SIBO is kind of a small bowel disorder, right?
Right.
But I think that the future of at least physiology testing and irritable bowel syndrome will be looking at the small bowel. It's been one of those places that's really tricky to get to, okay? Because it's kind of almost too far to go from the mouth with a scope, too far to go up the back route with a scope.
It's a long way.
Yeah, it's a long way. But there's a lot of, we've already alluded to this, a lot of small bowel disorders that are manifest as IBS. The pancreas is there, and there's the gallbladder, lots of other organs there. But with SIBO, what we've been doing, at least at the Functional Gut Clinic, is we have been giving lactulose, which is a non-absorbable sugar. It's used to diagnose SIBO. It works perfectly because our body can't break it down, so we don't have any enzymes to break lactulose down. So what it does is it moves all the way through your gut, right? So as it's moving through different points in the gut, there's different bacteria feeding on that lactulose, and then they're giving off different gases and metabolites. So to evolve the next stage of assessing the gut and the gut microbiome, and actually the function of it, right? Because gut microbiome testing so far just kind of tells you what's in there, maybe how diverse your gut microbiome is. That's about as interesting as it gets. But what about the metabolic consequences of that what are those microbes actually doing and producing, which could be affecting health, right? So we have a PhD student who has been looking at this. We're giving a lactulose probe, basically, and then measuring not just gases in breath, but metabolites. We're measuring VOCs, these are volatile organic compounds. So we can look at things like short-chain fatty acids, so butyrate, propionate, acetate, and lots of other compounds that these microbes are giving off when they're feeding on, in this case, a lactulose, but you could pretty much give any other non-digestible probe, right? And what we're trying to do is map the differences in people with GI disorders like irritable bowel syndrome versus healthy volunteers, to see if this is the route that we should be targeting, and then ultimately that could shape microbiome related therapeutics,
right,
like prebiotics, probiotics,
right,
FMT. So I think the future is in the small bowel to look at all these other potential disorders that manifest as IBS, and then also looking at the consequences of the microbiome, so the metabolome rather than the microbiome itself.
So it's about moving beyond the current knowledge, which is focused predominantly on stool testing.
Yeah.
And for the listener who might be thinking, well, why have we not just gone straight to the small bowel? Well, as you alluded to, they need to stop calling it the small bowel. It's not the small bowel, it's the small intestine.
Yeah.
You've got to put a tube up and then down, and that's
Yeah.
quite a long way to go. And you talked about the contamination earlier as well. And stool is just much easier to obtain, right? It's non-invasive. I suppose it is a proxy for what's in the small bowel because it's got to travel down. But it's not giving you a representative sample of what's going on in the area of interest, right?
No.
So what you're talking about is a non-invasive means of trying to establish what's actually going on in there from a microbiome perspective. Yeah. And then that then allows us to funnel treatments.
Yeah.
Like, as you talked about earlier, the rifaximins.
Yeah, exactly. So it's how we look at this, and we've got potential with the breath VOCs. I think there's now a capsule that you can take that potentially samples different parts of the small intestine, so the duodenum, the jejunum, the ileum. So yeah, that's pretty cool. And then going back to, again, the small bowel, there's things like pancreatic insufficiency, looking for easier ways to diagnose that, easier ways to diagnose bile acid malabsorption, all these things that manifest as irritable bowel syndrome. But what's really cool and has opened up this interest in the small bowel is actually sequencing it. So when you do a stool microbiome test, it's basically just a reflection of what's right at the end of your GI tract, right? What's right at the end of the intestinal tract. But there's a group in the States, so that's Dr. Mark Pimentel and Dr. Ali Razai. They do the MASS program, and they've been sequencing the small intestinal microbiome, so the duodenal microbiome. And what you see is starkly different to the stool microbiome in the same person. So a stool microbiome test doesn't give you any indication of what's going on further up the gut in the small bowel. And when you think about the length of the small bowel, right, compared to the colon, I know there's a lot more microbes in the colon than the small bowel, but the small bowel is like 15 feet. It's where most of the immune system cells reside in the gut. So you have this literally one layer thick intestinal lining, right, that's got loads of bacteria on one side, and then on the other side is all these immune system cells that are constantly sampling that environment. And so I think we need to pay more attention to the small intestine. And yeah, I do think that's where the future, at least with gut health and GI disorders, is going to be. Yeah.
Can I just bring you back to the functional gut clinic then, where you're currently working? What kind of services and research is the functional gut clinic operating in and offering?
So we offer a range of diagnostic tests for gut health, so from top to bottom, so we look all the way through the gut. But with the functional gut clinic, we do both NHS and private work, right? But we're mostly a tertiary-based service, so the people that we see are referred on to us, and they've already been to see their GP a few times. They've been to see a specialist. They've probably had tests done to rule out inflammatory bowel disease and celiac disease, right? So they're quite far down in the patient pathway. And what we want to be able to do is to try and... So this is with the invention, I'm probably digressing a little bit, but we've had our new venture, which is Tummy MOT. One of our mottos is to try and prevent people from becoming patients and having to go down this really long pathway, right? And that includes not just doing tests, but actually looking at what over-the-counter treatments are available that can help people, right? But just going back to functional gut clinic, we have a massive R&D development. We've ran clinical trials in the past, and we've got some really exciting ones coming up. So recently we've done stuff with probiotics in healthy volunteers, which gave us some really surprising results that I think we can probably talk about.
Yeah.
We've done stuff with we've done stuff with big pharma companies, right? And next year we've got some really exciting trials in irritable bowel syndrome, including the one we're doing with EBX. Yep. Okay, so we're going to be looking at it in IBS, right? So we lots of exciting stuff planned, but yeah, with some of the stuff we've done already. So the probiotics one was really interesting.
Yeah,
so,
let's talk about that.
Yeah, we basically probiotics, right? People know or may not know that they're live microbes that when you ingest give you some sort of health benefit. And
that's the World Health Organization definition summarised in a nutshell, right?
Exactly.
They should give a health benefit.
They should.
By name, as in if they're called a probiotic, they should deliver some sort of health benefit in specific circumstances, right? That's been tested and proven.
Exactly, right? So with a probiotic, what you're looking for on the label is actually this number or sequence of letters after the name, which is the strain identifier. So one example could be, Lactobacillus reuteri. I think it's actually been renamed to Lactobacillus reuteri. Let's just call it L. reuteri for simplicity. Yeah. So L. reuteri is the species of bacteria, but to identify the strain, there should be some numbers after it. So L. reuteri DSM 17938 is a really well-defined probiotic with lots of potential health benefits. Okay, and why you need to know that strain is super important. Firstly, you can use that strain to see what it's potentially helpful for, right? So you could go to a literature database like PubMed or Google Scholar or Web of Science, and you can put that strain identifier in, and it'll give you all the studies that have been done on that product and what it could potentially help with, all right? And it's super important because the bacteria are kind of like dogs, right? Yeah. So different breeds have different characteristics, just like different strains of bacteria.
Right, because you wouldn't see a Chihuahua as the same as a Great Dane or a Rottweiler,
exactly.
Right? Very different.
You wouldn't choose a French Bulldog to herd sheep, would you? So you want to know exactly what you're getting. So this strain is really important.
Should we just use maybe E. coli to sort of exemplify this for the listener, right? So E. coli is a species, but there's many different types of E. coli in terms of strain. And on the one hand, you could have E. coli Nissel, for example, which is a common probiotic in Germany, predominantly. And you can also have E. coli 0157, which is a category 3, for those of you who don't know what that means, biohazard, insofar as it can cause very serious harm to people, potentially even death, typically by acute renal failure. So your kidneys shut down. Bad. But that's all E. coli.
Yeah.
And you'd actually find E. coli in most people's guts in various different percentages. Yeah. But that's typically the non-harmful E. coli. So that just exemplifies why it's so important to get the strain and not the species, right? So over to you
That's
again.
a great way to demonstrate it. So it's really important to know the strain. A lot of products don't actually list the strain, right? So you go into a generic health store, you'll take their bacteria supplement, you look on the back, it doesn't have the strain on there. And that's a huge red flag to me, because you don't know exactly what you're getting. It might suggest a few other things as well, like poor quality control. They don't actually know what strain's in there.
We're laughing, but,
but
we shouldn't laugh.
Yeah.
We're laughing because it's actually true.
Yeah.
And it shouldn't be true, but it's actually true. So get the strain.
Yeah. So you want to know the strain, and then you want to know what it potentially helps, right? Another thing at the minute, which a lot of companies doing, which I think is pretty wrong, is they're piggybacking claims off independent studies of different strains, right? So what they'll do is they'll just make their own probiotic supplement with, say, 10 different bacteria in there, and they'll say, our product has over 100 studies behind it. And when you look, right, they've just put 10 different strains together, which do have maybe 10 independent clinical studies behind them, but that doesn't mean that the mixture of bacteria they put in their product has the same effect, right? And they might not have the adequate dose in there. So they might have a product with 20 billion bacteria in, but they've only used 2 billion of one strain, when the research shows actually need at least 10 billion to get that health benefit, right? So
I'm with you 100%. I think we mentioned before we got rolling with the cameras, one particular company, which I won't name, and me having this debate with someone on LinkedIn, because this person, who I think was an investor, again, shall remain nameless, was like, there's been 300 or something of that order of magnitude number of studies. I thought, why have I not heard about this before? So I did a bit of research and I found 0 studies on the actual product, right? So what they had done is just amalgamated as many studies that they possibly could find on particular strains, bundled them together and said, our product is backed by X number. And it's like, well, no, it's not. Your product is backed by 0.
Yeah.
Right?
Yeah.
Because the dosage and the formulation and the other potential probiotic strains that you've got in there haven't been tested in combination.
Exactly right.
Right.
Who knows if they might even cancel each other out, and there's a little bit of evidence for this when you look at the meta-analyses of probiotics for antibiotic-associated diarrhea, right? So one of the well-documented strains that is helpful is L. rhamnosus GG. But when you look at the meta-analyses, in some products where it's combined with others, it's not effective for antibiotic-associated diarrhea, right? So these bacteria might not be getting on in the supplement, and it might cancel out some of these effects. So, I think it's a little bit dodgy making those claims. But
can we go a little bit deeper then on what people should look for? So we've talked about the strain.
Yeah.
What else should people look for?
So should look at the strain. Dose is important, but just because a probiotic has more bacteria doesn't mean it's necessarily better than another one, right?
Right.
So another thing that companies will do is like, ours has 25 billion or 50 billion or 100 billion CFUs. So CFUs are the colony forming units, like the dosage of the bacteria. So you'll think, oh, yeah, I'll have the 100 billion one. Those are usually the ones that have absolute who knows what's in them, right?
Have you been to a health food store in the US?
Yeah. Oh, not in the US.
Oh my goodness! I laugh every time I go. So I because I'm a bit of a microbiome nerd, I will go to. So I was just in Planet Organic about, I don't know, half an hour before we went on the podcast, and I did go to the section with probiotics. And in the US, it's actually comedy, because it's just American,
Yeah.
insofar as it's about, huge numbers plastered all over. We've got more than anybody else. And it's like, isn't necessarily better, right? It's about what you're taking.
Exactly.
And it's about the quality control associated with the product.
Yeah. There's some probiotic strains that only need 1 billion to work, or even less. I think El Roux Terrier DSM 17938, which is BioGaia, needs even less than that to have an effect. So just because it has more doesn't necessarily mean it's better.
Right.
But that's funny about America. They supersize everything.
Of course they do. Yeah. It's all marketing.
Probiotics, yeah.
And to be honest with you, the probiotics industry, I'm sorry to say this is no harm to any one particular person or company, but it's actually predominantly a marketing game at the moment, right? It's, who can shout the loudest, who can get in front of the most people at the right time. Whereas what it should be, and I'm hoping we get to this in the conversation today, is it should be evidence-driven. Yeah. Right? And that's kind of what you're trying to do with Tummy MOT. So pause that for a second. Anything else people should look for?
Yeah, so we've got the strain identifier, we've got the dose, and then I think that just knowing what that is helpful for, right?
There we go.
Yeah. So that's where Tummy MOT comes in, which is a new company that we've launched. Basically, we were sick and tired of seeing companies promote their products in this way when they had no clinical evidence behind them. We were getting patients come to us down this, long tertiary pathway, and they're coming to us taking half a dozen or more different gut health supplements.
At the same time?
At the same time, right?
Wow.
So
out of their own pocket as well.
Out of their own pocket.
Let's not forget that.
Yeah. So out of their own pocket, they're still getting symptoms. So at most they're doing nothing. At worst, it could potentially be harmful, right? Because of a lack of quality control in some products. You can get contamination by things like heavy metals So what the goal of, the main goal, there's several goals of Tummy MOT, but the main goal is we actually review these products in a systematic way, right? Just like a systematic review. So we'll take a product, we'll look at the claims that the company make. So let's say they say their product helps bloating. Then what we'll do is we'll do a systematic review, so a literature search. Firstly, looking for that product. Most of the time, that product isn't there. Ideally, it would be, but it usually isn't. So the next thing we do is we look at the individual ingredients or with probiotics or strains, and then we search them in the literature. And then based on what we find, we give that product a rating. So if the ingredients or the products have randomized, controlled clinical trials showing a positive effect, then that gets a trusted label. If the product or ingredients have some evidence behind them, but it's not quite the gold standard, so maybe some open label, single arm, that kind of thing, then they get a one to watch, right? So it's positive, but we need that gold standard, right, to be fully confident. And then if that product just doesn't have any clinical evidence behind it, or the ingredients that they've got in the product aren't in the correct dose, so going back to probiotics, they aren't in the correct dose, or they're basing it on like animal and lab-based models, not human trials, then we give them an unproven rating. So what people can do is they can go to the website.
What is the website?
TummyMOT.com.
Yep.
And then you can hit
just for the people at home, you can't see. For those that are watching, you can see we're wearing a Tummy MOT t-shirt today. Yeah. I'm happy to be representing it. I think the work's very important. Yeah.
Love it. They go to TummyMOT.com, they go to the review section, and what they can do is they can filter by what they want to improve, right? So say that they want to improve bloating, they can filter by bloating, and all the products that have been proven to work in clinical trials will come back, constipation, whatever indication. Right? And the other incentive is that people can actually recommend the products that they're taking or interested in to us. And one of our team members will do a review on that product and then hopefully put it onto the website.
Which adds to the database, right?
Yes, exactly. So at the minute, we've got this huge database of products and ingredients and strains. So it's actually getting a lot more easier to review them the more that we do, right? So we welcome people to recommend products. But yeah, going back to probiotics, it's really interesting because what people think is to take a probiotic because it's going to improve their gut microbiome diversity. These bacteria are going to make their way into the gut, they're going to live there. That's just simply not the case. So our recent research showed this, and it's supported by previous research. So what we did was we gave 40 healthy volunteers, so healthy people, no tummy issues. We gave them a multi-strain probiotic for 3 months, and we looked at the microbiome before and after. And what we saw was that even after 3 months, there was no change in like alpha or beta diversity. Okay, so no change to the diversity of the microbiome, which was pretty, you'd have thought it would be.
Well, something would happen, yeah.
But even previous research shows that in healthy volunteers, probiotic supplementation at least doesn't change the diversity of the microbiome. But what was pretty novel and interesting about our study was that we saw that some of the functional pathways of the microbiome were upregulated or downregulated. Right?
Post-administration,
post-consuming
them, yeah.
Exactly. We couldn't say whether these changes were good or bad because there wasn't a lot of other data in the literature on that. But it's quite interesting, and it kind of alludes to how probiotics probably work, in that you take them, they move through your gut, they interact with your resident microbes in your immune system, and then they pass out, right? They don't stay in your gut, they don't make it their home. And it's quite good actually, because you wouldn't necessarily want them to stay. If you imagine your family or friends coming over for dinner, you enjoy it, but at some point you do want them to move on, right? And I think that's a little bit like how probiotics work, and it's probably why if you're taking a probiotic and it helps your indication, it helps your bloating, it helps your constipation, you probably need to keep taking that long term, yeah,
because it's not sticking around.
Yeah,
it's kind of interesting because a lot of the companies working in the space, and I guess now we're moving into the field that I'm working in, they're obsessed with something called engraftment, and there's kind of controversy around the term, right? I'll try and break it down into the simplest terms possible. So primary engraftment would be a strain that's present in the product, that's not present in the patient before they get the strain, and then appears post-intervention and then persists as per a defined period of time. We can discuss how long that typically is. That's primary engraftment. Secondary engraftment is a strain that appears post-administration that's not in the product, but may be part of, I don't know, the environment or through a contact with someone they're close to or through food or something along those lines. And engraftment is, for many companies, a measure of what we call pharmacokinetics, which is how drug substance moves through the body and sort of stays within the body after administration. It's a very well-known and well-described pharmacological term, right? So I've always asked the question, why do you need engraftment? And then these companies will say, well, of course, you need the strains to stay there so they can produce their effect. But I've always kicked back and said, well, what if it's just the presence of them being there? Even if it's just transient, that has some sort of effect. And what you've shown, I think, is you don't need engraftment to have some sort of physiological effect. That's what you've shown, in essence.
Yeah.
Can you talk more about what physiological effects you saw, or is it too notional at this stage to really dig into it?
Yeah, unfortunately at this stage, at least in our study in the healthy volunteers, we can't say, because we saw changes in the metabolome, but we don't know if they were positive or negative. And I think
metabolome for the listener is essentially the summary, if you like, or the sum factor of everything that the microbiome is producing.
Yeah.
Right? So if you imagine the microbiome is an orchestra, the orchestra plays its music, the music is the metabolome.
Yeah.
Something like that, right?
That's a good analogy, right? So we didn't look at many other health markers, so we didn't look at other biomarkers in the blood and stuff.
Right.
We did look at symptoms, but I think in order to understand, whether these consequential changes are having a benefit, you probably need to look in quite a bit of detail at other physiological systems. But it kind of shows where future study needs to go, right? So as a healthy person myself, should I take a probiotic? Well, I don't, based on the research. Okay, so I don't take a probiotic. I would, for one reason. Well, two reasons. If I was prescribed antibiotics, I would take it. And if I was going to travel somewhere a little bit exotic where I might be at risk of getting, traveller's diarrhea. But I think the best evidence we have for probiotics at the minute is irritable bowel syndrome, that's IBS, constipation. I would say, again, antibiotic-associated diarrhea, so reducing the risk of getting diarrhea from antibiotics, and also improving the eradicacy of H. pylori. So for H. pylori, you have a pretty harsh antibiotic regimen, but there's some evidence to show that certain probiotics can improve that eradication rate, so you're more likely to get rid of it. And then I think 2 other indications, which is where probiotics should be used alongside standard medications. One's ulcerative colitis, and the second is actually depression. I think there's quite a lot of positive evidence. Not anxiety, but clinical depression.
Now, there's almost certainly going to be a listener, many listeners, who either have one of the things you've just mentioned as a potential indication, or know somebody who has one of the potential indications, or they're potentially away travelling. Which then I think leads me on to the question of, where do they start?
It's a good
Is
question.
this when we say Tummy MOT?
This is where I'm going to go back to Tummy MOT.
That's good. Yeah, that's good.
Yeah.
That is good. That we now have a resource available.
It's a free resource. And I must reiterate that all the products we have on there cannot pay to be on the... It's purely based on scientific evidence. So we remain as impartial and unbiased as possible, purely based on the evidence. So if they go to the website, tummymot.com, go to review section, you can search by... So we've got like ulcerative colitis, all the probiotics and other supplements that have been shown to help with ulcerative colitis, or they can look at travel if they're going on holiday and they want to know which probiotic they need to take to prevent themselves, well, to help reduce the risk of getting traveller's diarrhea.
So this is to prevent the deli belly or whatever it's called.
Yeah, exactly.
So you take it before you go away to build
and
up
whilst you're away. Yeah.
Interesting.
Yeah. But there are other. It's not just probiotics on the website. There's prebiotics. There's just other over-the-counter supplements as well. So it's again, I want to say that we're trying to prevent people from becoming patients. So if you're already a patient, you can go to the website. Yeah. But if you're just getting the occasional bit of heartburn or the occasional bit of bloating and you just want to try something to see if it can resolve that before you need to go be referred on to a specialist and then they're sending you for more invasive tests, then just go to the website and see what's available.
Thank you for that.
Yeah.
So we've talked a lot about probiotics, how to select one, good indications for probiotics, or potential indications, I should say. We've talked now about the Tummy MOT. I think it brings me on quite nicely to some of the other things that are in our toolkit. So prebiotics, for example. So should we just start off with what a prebiotic is, and what is your experience of probiotics and how they sit within the kind of potential therapeutic toolkit or something that someone could take themselves?
Sure. So prebiotics are usually foods, or they can be supplements that, when taken, they support the growth of good bacteria in the gut, and then that gives you some sort of health benefit, right? So again, it's that focus on you have to have a health benefit from taking the prebiotic. There are foods that naturally contain prebiotics. They're usually vegetables to some extent, but their supplements are also quite interesting because what they do is they take the prebiotics from the vegetables and they make it more accessible and more obtainable, right? So there's lots of different prebiotics. Again, we have some on the website. I think they're slightly different to probiotics. This is something as a healthy person I would probably take every day, and I do take a prebiotic every day. So there's different ones that target different bacteria. So you can take a prebiotic that targets bacteria that produce butyrate, for example. So butyrate is a short-chain fatty acid that's super important for gut health and actually functioning of the gut. So you can take a prebiotic that supports those. You can take a prebiotic that supports things like bifidobacteria, which are, again, important for immune health. So yeah, I think prebiotics are definitely more appropriate for healthy people, and it's something you want to take every day just to maintain the good bacteria in the microbiome, whereas I think probiotics are probably a little bit better for certain indications.
If someone wants to start taking a probiotic to improve their health, and I know you're probably going to say go to Tummy MOT, which is cool, what are some of the general guiding principles? You talked about vegetables. Is there like a certain group of probiotics? I've heard of
prebiotics.
Prebiotics. I've heard of inulin, for example. There's the celluloses.
Yeah.
Which type of fibre?
So there's one thing that we should say about prebiotics is that you can get fermentable and non-fermentable prebiotics. And for people with digestive issues like irritable bowel syndrome, IBS, prebiotics can actually be a little bit tricky and provocative to their symptoms, because what happens is if they do have an imbalance in the microbiome, they do have SIBO, then they take a prebiotic, it gets fermented, it produces a lot of gas, you get the bloating, you get the tummy pain, right? So there's fermentable and there's non-fermentable prebiotics. My favourite prebiotics tend to be the or less fermentable ones, right? These are things like partially hydrolyzed guar gum. So the actual fibre, the prebiotic, has been partially metabolized by bacteria already. So it's less likely to cause symptoms when you take it. It has a multitude of potential benefits for both constipation and also diarrhea. And it's also a kind of soluble fibre. So again, some of the best prebiotics tend to fall under the more soluble fibre arm, right? Because you've got so we've talked about partially hydrolyzed guar gum in foods. Another one of my favourites is beta-glucan, which is found in oats, and actually mushrooms are a really good source of it as well. Inulin is a fermentable.
So just one question. How do people know if the partially hydrolyzed guar gum is in their food or not? Is that
so this is the thing, it's not something that's found in food, right? So guar gum is a naturally occurring substance, not necessarily found in foods. It's added to a lot of foods. It's actually a commonly used emulsifier that some people might be scared of.
Oh, this is a controversial
Yeah,
subject,
this is controversial, and we can get into emulsifiers as well. But there's a lot of different emulsifiers, just like artificial sweeteners and sweeteners. Like some of them are probably okay and some of them less so. So guar gum is actually been shown to be beneficial in studies, right? It increases levels of butyrate-producing bacteria. So these are the bacteria that produce butyrate are normally the fermenters. They like to feed on stuff,
right?
Like feed on fibre. Partially hydrolyzed guar gum is you take the guar gum and you hydrolyze it, usually from a bacterial source, right? And it still promotes the growth of butyrate-producing bacteria, but it's less harsh on the gut, should we say. So actually people with sensitive stomachs can usually take this, whereas they struggle a bit more with the guar gum. But that's a unique prebiotic, right? There's prebiotics in foods like beta-glucan, we've just touched on, inulin. But inulin is another super fermentable prebiotic, which is found in garlic, onions, and it's what sets a lot of people's IBS off. It's actually a FODMAP. So FODMAPs are fermentable carbohydrates, basically. And if you've got irritable bowel syndrome, you probably have tried the low FODMAP diet at some point, which is where you remove these foods, so usually plant foods, right? So fruits, vegetables, grains, nuts, seeds, that are high in these fermentable compounds. But those fermentable compounds are usually prebiotics. So when you go on the low FODMAP diet,
right?
You lose a lot of your beneficial microbes.
Yeah. So you're reducing diversity.
You're reducing diversity,
almost,
exactly.
Right?
Yeah, exactly. But what happens with the low FODMAP diet is it's not a lifelong diet, right? It's actually an elimination diet, and then you reintroduce certain FODMAPs because you might just be intolerant to the inulin, right? But you're okay with other stuff. But what a lot of people do is they end up on the low FODMAP diet for life in the restrictive phase, when really after 3 months they should know which FODMAPs they can't deal with. And I will say, if you've tried the low FODMAP diet and you're struggling with different FODMAPs like fructose, like inulin, like lactose, so you're struggling with more than one, then that might be when it's something like small intestinal bacterial overgrowth that's manifesting as. Right. Yeah, all right. So when these prebiotics are hitting the small bowel, these bacteria are having a go, and you're getting the bloating, which is, again, why some prebiotics aren't for everyone. And neither are probiotics. But
on this low FODMAP diet, then, is this a potential avenue for people that have got diarrhea predominant, just going back to the start, constipation predominant mix? Is it a good thing to try for everybody?
Yeah, so it's the most effective diet for IBS when you look at the literature. But yeah, it's restrictive in the first instance because you're removing a lot of food groups, and we know that affects diversity. Diversity is super important because the more diverse your microbiome is, there's more it's associated with more health outcomes, and there's animal studies to show that having more diverse microbes, you're less likely to develop different diseases and intestinal infections and so on and so forth. So it's really important, but actually the studies show that when you finish the low FODMAP diet, your diversity is pretty much back to baseline. But people just need to remember not to stay in the restrictive phase, and that's why I usually recommend doing it with a dietitian.
Yep.
Unfortunately, a lot of people get their advice online or just from the doctor. They give them a leaflet, don't eat these foods, all right? But then there's no sign of reintroduction. But when you start to reintroduce some of them fruits, those vegetables and other plants that have the fibres in, which support the gut microflora, then yeah.
So what is a kind of gold standard low FODMAP diet then? So there's like an initial phase where it's really restrictive.
Yeah.
What happens after that then?
So there's a restrictive phase. There's a reintroduction phase where you take one of the kind of FODMAPs. So, for example, sorbitol, which is a sugar alcohol, and it's found naturally in plants. So it's found in avocados. So what you might want to do is, during the reintroduction phase, you add half an avocado. And then if you get your symptoms after that, sorbitol probably isn't your thing, right? Or if you're okay with that, the next time you might add another quarter of an avocado to find your threshold of the sorbitol. Right?
Got it.
Because everyone's gut has a certain threshold of what they can ferment. And the final stage is the personalisation. So you know which ones work for you, which ones don't, at what levels. So you have a personalised diet which incorporates these, and that's why you usually need a dietitian to support you, because it's pretty complicated to do that all by yourself.
And how long would that typically take then for somebody?
3 to 6 months, no longer than 6 months definitely, but somewhere around.
And by that time you should know what your triggers are, and it's less restrictive than it is just cutting out all FODMAPs.
Yeah.
And then perhaps you get the benefit of some of these fibre-containing foods, polyphenol-containing foods, good fat-containing foods, which you have to restrict yourself from with the FODMAP. Yeah.
And we probably should say, you just alluded to them, things like polyphenols. So prebiotics aren't just fermentable carbohydrates, fermentable fibres, right? Polyphenols are another exciting potential area of prebiotics. So these are like the antioxidants, basically, that give different plants their colour. So the blue in blueberries, the red in purple in a purple cabbage, that kind of thing. Yeah. So
these polyphenols are unbelievable.
Yeah. And you can actually, so if you go in on a low FODMAP diet, for example, you can try and focus on some of these polyphenol-rich foods that might not be as fermentable.
I like that.
Like your extra virgin olive oil, like your berries. So berries are typically low FODMAP.
And low fructose. Yeah, well, maybe that's why they're low FODMAP.
Except blackberries, but the rest of them.
Yeah,
the rest of them are.
Blueberries and raspberries are awesome. In fact, if you could just pick one food for the microbiome.
One food? That's a good question.
But seriously, what would you pick?
It would actually be yogurt.
Right? Okay, we can have a debate about this. Tell me why. Tell me why.
Have you? So there's lots of reasons. I think the superfood title is thrown around a lot, and I'm not a fan of it.
Yeah.
Okay. But I think if I had to pick one, it would be yogurt, and that's because we have a lot of good evidence. Meta-analyses showing that.
What kind of yogurt?
Oh, so just dairy,
just standard
fermented dairy.
Fermented
dairy. I should specify. Not plant-based yogurt. Okay. Just because we don't have the evidence, right? So fermented dairy, yogurt, and also kefir I'd probably put into the bracket as well.
Gotcha.
So fermented dairy, a lot of evidence, meta-analyses to show that it is associated with a reduced risk of colorectal cancer. It's associated with a reduced risk of cardiovascular disease, a reduced risk of diabetes. And what I always say is, have you heard of the food matrix?
Of course.
Yeah.
For the listener.
Yeah, so normally when we talk about a food, we say, it's nutritious because it's high in some sort of nutrient, right? So you might say oranges are great because they're high in vitamin C, or spinach is good because it's high in iron.
Yeah.
But in reality, no single nutrient defines your diet, right? So the food matrix looks at like all the nutrients and non-nutrients in a food. And yogurt has a really unique food matrix because it's a great source of protein.
Yep.
It's got whey protein and casein. It's got all 9 essential amino acids in there. It's a great source of fat. So we've got bioactive fatty acids in there, like conjugated linoleic acid associated with health outcomes. It's got lots of vitamins and minerals, right? Vitamin B12, vitamin D, calcium, selenium.
You're making a good case.
Yeah.
Yeah, you're making a
And
good
then
case.
the fourth unique element is it contains live bacteria, right? It contains these live lactic acid bacteria, which in themselves are associated with numerous health outcomes.
100%.
Yeah.
Yep.
And when you look at other foods, not many of them compare in terms of the food matrix to fermented dairy.
You've made a very, very good case.
Yeah, yeah.
And I'm sure, am I going to be able to top this? Well, the good news is the one that I'm picking goes very well with yogurt. I would pick the blueberry. I am blueberry mad. And I'll give you a couple of reasons why, okay? So from a kind of convenience perspective, if you put them in an airtight container, you can kind of take them anywhere, right? And they don't spoil, they're not messy. You just dip your hand in, boom, and you've got a handful of goodness. So that's just a really practical kind of point. And if you go on hiking or so on, you can take your blueberries with you. 2, high fiber content. 3, very low fructose content. 4, very high polyphenol content, right? And I think that kind of quadfecta, whatever it's called, of things makes it really, really awesome. It's also really micronutrient rich. So very high in magnesium, for example.
Well, I think combining blueberries and yogurt sounds like we've got the ultimate.
Yeah, no, it is.
Food, right?
For sure. What is lacking is the macronutrient.
So you like the protein and
Exactly.
the fats.
That's what it's missing.
Yeah,
It's
yeah.
missing the macronutrients. But when people say, how do I improve my microbiome? Like, give me some easy steps. They probably think I'm going to say, well, you need to take a specific probiotic and you take the probiotic 3 times a day.
Yeah.
No, just eat more blueberries. That's a good start. And you could maybe eat some more raspberries, and then you can maybe eat some more artichoke. Then you can maybe eat some more spinach. And in fact, before you know it, you're eating 10 or 15 different colourful things by the end of the week. You're smashing your macronutrient content. You're not really high in refined sugars because they've got complex carbohydrates. And suddenly you start to feel a little bit better. Suddenly you're not running to the loo like you were. You've got energy throughout the day. Maybe your body composition starts to change. And I think there's 2 elements to that. One is the direct effects of those macronutrients on your body. But the other element is, how is it changing your microbiome? And one of the things I find fascinating is people talk about all this healthy food advice. And you could probably pull 100 people off the street in Shoreditch, near where we are now, and say, so how do you sort of be healthy? And they'd say, stop drinking, stop smoking, exercise a little bit, maybe eat some more fruits and vegetables. And then you could ask a microbiome expert, how do you improve your microbiome? They'd say exactly the same thing, right?
Yeah.
So maybe our historic health advice, which makes us healthier, is actually microbiome and gut health advice, right?
Yeah.
So, anyways, I went on a bit of a sort of rant there. This is kind of your podcast, not my podcast. You're the expert, so we'll bring it back to you. So we've talked about probiotics, prebiotics, polyphenols. Is there any sort of general advice we can give to people about how to mix and match? So you mentioned that prebiotics probably for everybody, right?
Yeah, for most people. Just be careful if you have a sensitive stomach. It's not a fermentable. If you're going to supplement it, right, it's not a fermentable one.
And to get that info, they could go to Tummy MOT.
MOT.
They could probably ask ChatGPT
Probably.
about because I've started to do that as well now. Just as an aside, like one thing that people could do if they were feeling, maybe lazy is the wrong word, but they could actually ask ChatGPT to analyse what's on Tummy MOT. Have you asked it to do this?
No, I've not.
I have. Not specifically Tummy MOT,
Yeah.
but I can give you, if you listen to some of my solo podcasts, I talk a little bit about sort of how to get maximum bang for buck in terms of time expended on a particular task, and how to build a supplement stack if you're not an expert through ChatGPT. So what you need to do is give ChatGPT the right sources, because what I've found is it's quite good at summarizing data that you give it, but it can be a little bit off if you ask it really big questions and don't give it the right sort of feedstock and info. So you could say, I have these goals. So for example, I'm going to Delhi and I want to prevent Delhi belly. I want some general advice about how to build a resilient microbiome, and I want to gain 10 kg of muscle over the next year, which is quite a lot. Could you summarize the best evidence from your Instagram account, which, by the way, for the listeners, Mr. Gut Health, examine.com, which is this awesome supplement website, which, by the way, I recommend you take a look at if you've not taken a look at it already. You will love it because you're a bit of a nerd, no harm, in the positive sense, and you would love this. And Tummy MOT, and it would jump in and it will summarize based on all the sources and cite the sources. And before you know it, you've got 5 pages of well-referenced. It's mad. I'll show you after we stop recording. I'll show you after we stop recording because I think it's going to elevate your research to the next level because you're already so well read. It will allow you to really delve into areas that it would take you a long time to get into and try and pull out salient points. So I don't know how I got to this. So back to Tummy MOT for prebiotics, right? But what are sort of other general recommendations to people for wanting to build a prebiotic stack? And this relates to diet, which we should talk about as well.
I think you've already spoke about the diversity of colours, diversity of plants. I think one thing that we really need to focus on as well is more fermented foods.
Yeah.
Right. So there's actually a study that was published which showed that fermented foods might actually be better than fibre for increasing diversity in the microbiome. Right. So they took some healthy volunteers, people without stomach issues, and they randomised them to a diet that was high in either fibre or a diet that was high in fermented foods, right? So it's like 6 servings or more per day of fermented foods. I think it was like 25, 30 grams of fibre a day, right? And the group who ate more fermented foods saw an increase in gut microbiome diversity and a reduction in biomarkers of inflammation.
Wow. But
the fibre group didn't see any increase in diversity or a reduction in inflammatory markers. I mean, it was a relatively short study, right? But I think fermented foods, even though there's not a ton of evidence behind them, might be the next best thing for the gut because they seem to contain the prebiotics.
Yeah.
I don't really like saying they contain probiotics because probiotics have to be strain specific. So I'm going to say they contain live bacteria that might be helpful. And they may contain these postbiotics, right, which is this new term. So if you imagine a sauerkraut, okay, you've got the cabbage.
Which is a fermented food.
So sauerkraut is fermented cabbage. The cabbage is the prebiotics. The live bacteria, the lactic acid bacteria that ferment on it, they're not necessarily probiotics, but they're good for you. And then the postbiotics are when these bacteria are feeding on the cabbage during the fermentation process, they're producing metabolites that are important. And then also when you pasteurize the cabbage, right? So there's a lot of debate on whether you should be eating live fermented foods that are from the fridge or fermented foods off the shelf, right? So
what's the answer to that?
So I say both, right?
Oh, interesting.
Okay, so I'm going back to sauerkraut here.
Yeah.
Actually, it was a study with kimchi, but I think there's been one with sauerkraut as well. So kimchi is a fermented, it's like a Korean cabbage, right, with spices. They found that actually when they gave it to people with IBS, both the pasteurised and unpasteurised, so the living and the technically dead kimchi, both led to positive changes in the gut microbiome. So it might actually not be the live bacteria which are causing these changes, but even when they're killed, right, they become postbiotics. So those bacterial cells are dead. The metabolites might still be active, and they're probably having still some interaction with the immune system and the resident gut microbes. So
so it's entirely plausible that even if a dead bacteria is in something you consume, that dead bacteria still has an immunostimulatory effect.
Exactly right. Yeah. Exactly.
Because it recognises some elements as foreign.
Yeah, so your immune system may connect to something on that dead bacteria that's positive because it's used to it being a resident microbe, right? So I say both, right? So live, unpasteurised and pasteurised, but fermented foods. Try and get that. It's only one study in healthy volunteers. 6 servings a day sounds like a lot, but
6 a day?
6 servings a day, right? But it's actually achievable when you think you could have yogurt with a bit of kefir for your breakfast, okay? For lunch, you could have some fermented vegetables on your sandwich. So you could put some pickles on there, right?
Right.
You could have a drink of kombucha. So there's not a lot of evidence to show that kombucha has any benefits. But in that study, you can actually look at what each individual participant had for their fermented foods, and I think there was like one person who just had loads of kombucha.
And did they have benefits?
Well, collectively there was benefits, right? Because other
Interesting.
people had kombucha in that study as well, not just him. But I just thought that was quite funny.
That is really cool.
So, yeah.
Just a kombucha
So,
addict.
Yeah. It must have just been like the easiest thing for him to get, right?
Do you drink kombucha?
I do.
Yeah.
I do. Even though there's not loads of
Me
evidence
too.
behind it, I just really enjoy.
Me too.
I enjoy the taste of it, and that's
Yeah.
what matters most, right?
Yeah.
find it
We had one in the office for a while that tasted like a margarita.
Wow.
I'll send you. I don't mind saying it. It's a company in
That's
Glasgow called You and I.
Right.
I've been to a kombucha masterclass by the two founders. I can attest to how passionate they are about
Yeah.
kombucha, how passionate they are about the quality of ingredients, and everything that I've tried that they've made. I've no affiliation whatsoever to them, by the way. I just buy it and I drink it, particularly after the sauna. The lime salt one does taste a little bit like a margarita.
Like, nice.
Yeah.
So
yeah,
it's
yeah. Non-alcoholic margarita.
A non-alcoholic alternative,
Yeah.
right? So we have a company based in Manchester that's local to us called Hip Hop, and like we've been doing stuff with theirs recently. We did some mocktails using kombucha, right?
Yeah.
And I really like them because they're local, right? I think you should support local. But
100%.
they also add a probiotic strain into their kombucha. I mean, there's no studies to show
Right.
that it works in that kombucha, but I think that's quite cool.
That's very cool.
Yeah. So yeah, kombucha and pickled vegetables with your lunch, and then for dinner you might have like an Asian-inspired dish, right? You might have some miso mackerel with soy sauce, or tempeh, which is fermented tofu, or just
There you go.
even
Seven.
even you can have a shot of juice from the pickles, right? Because during that study, that's what they were also doing, just
Drinking from the jar.
drinking from the jar. Yeah.
So some people might think that's socially not acceptable, but what we're saying to you is, it is.
It is,
You
yeah.
can drink from the
Yeah.
jar. It's cool.
Yeah.
So that was actually 7, I think, if I counted correctly. Maybe
All
not,
right.
6 or
Well,
7.
pretty easy
But
to do it.
There you go. So you
Yeah.
managed to do it. But every day, I mean,
Every day, yeah.
the benefits are cumulative. They accumulate. And
Well, I think, yeah, obviously you're having that regular introduction, which is what's important. As we know with probiotic studies, and obviously once you stop taking something, usually at least the microbiome just returns to baseline, right, pretty soon. So you want to have that regular introduction of things to maintain.
So we've spoken a bit about, sorry to cut you off there, but we've
all right.
spoken a bit about things which are good for the microbiome. The prebiotics, the non-prebiotic fibre, although that's maybe just for general motility and
Yeah.
kind of moving things along. We've talked about polyphenols. We've talked about, in certain situations, FMT. We've talked about antibiotics, actually, in the context of rifaximin. But what about things that are bad for the microbiome? What's bad for gut health?
So I would say there's nothing that's inherently bad in that you have to totally avoid it, right?
Palm oil? Palm oil?
Palm oil. So seed oils is an interesting one, and we can get into it a little bit. So palm oil, seed oils, there's a lot of people on social media saying like these are the worst thing for you. And what I think is that there's a massive consumption of ultra-processed foods that contain these seed oils, but other additives like emulsifiers that might be having negative consequences on the gut and overall health. But what I will say is that there's a couple of seed oils that actually might be beneficial. So rapeseed oil is one, all right? I'm talking about cold-pressed rapeseed oil.
Okay.
Has a lot of polyphenols, a lot of antioxidants. Has a really good omega profile. In animal studies, I don't really like quoting animal studies, but that is the oil that induces the most, like basically leads to the most diversity in the gut microbiome when you give it to mice. But I think it's just got a bad rep because in the US it's canola oil and they process it really badly. And but if you have some British cold pressed rapeseed oil, really nice alternative to extra virgin olive oil, you can cook with, has a higher smoking point, so it's pretty safe to cook at high temperatures.
Right.
It's very neutral, so a lot of chefs use it because it doesn't actually affect the taste of the dish.
Interesting.
Right? So there's that, and then have you heard of? So we're going to probably move on to emulsifiers a little bit here. But there's these lecky things. So they seem to be in everything. You've probably seen it on the back of an ingredient that says soy lecithin
everything.
or rapeseed lecithin. Now, it sounds scary, but actually when you look into the research behind these they're basically fat, right? So it's not the oil itself, but it's like an extract from it. So you've got soy lecithin and rapeseed lecithin. In animal studies, there's no human trials to really support this, but in animal studies, it leads to an increase in butyrate producing bacteria when you give them these compounds. So I think they're not inherently bad. Although there isn't human data, I'd probably say they're okay.
Did I see you do an Instagram post on this?
Yeah,
I think I saw this. Yeah. By the way, for the listener, they should watch your Instagram. I really like it. I do genuinely really like it. I've learned a lot from your Instagram, seriously.
Yeah, so we try to offer a diverse range of content, but one thing we've done recently is actually going into supermarkets and showing you what you should eat.
I think that's
because there's a lot of people doing the opposite.
Yeah.
So so they seem to be an okay emulsifier. The gums, like the guar gum, the acacia gum, they're naturally from plants, and they again seem to promote butyrate producing bacteria. And there's more human studies on them that show actually they might reduce cholesterol as well.
Interesting.
So they're probably an okay emulsifier.
Yeah.
But they're naturally occurring emulsifiers, right? There's some that are more artificial that are added to foods, like polysorbate and carboxymethylcellulose. And these are the ones that, at least in animal studies, are associated with a pro-inflammatory, basically changes into the gut microbiome that promote inflammation. And there's actually now a human trial, at least one randomized controlled trial with carboxymethylcellulose, which showed that, at least in relatively high doses, within the recommended daily amount, but still quite high, that induced changes to the gut microbiome in humans that was pro-inflammatory, so that promoted inflammation. So I think there's a difference between these naturally occurring emulsifiers and additives versus the artificial ones. And I think that it's probably a similar story with the artificial sweeteners and the natural sweeteners, right?
Just about to jump into that. Yeah. So the aspartame versus the stevia.
Yeah, again, probably okay every now and again. If you want a Diet Coke, that's fine. If you incorporating these into your diet every day, at least based on animal studies, there's changes to the microbiome that might be negative. There is a human trial now, I think there's one or two, which show that, again, within the recommended daily amount, sorry, I can't speak.
It's all good.
They might have some changes to the microbiome, whether they're good or bad, we're not sure in humans, but a couple of them, which I think was sucralose, and then I forget the other one, actually led to changes in
aspartame.
Was it aspartame? Led to changes to the glycemic response as well. Yeah. So they're not inherently inert as well, right?
Some people think that's because of potential molecular mimicry. So the microorganisms chew them up, and in doing so, chew them up into substances that trigger, an insulin response, so glucose. So it's actually the microbiome that's changing the way that they're presented to the body, so they're kind of gobbling them up, which I think is kind of interesting, right?
Yeah.
If we're to summarise the current state of the art thinking on sweeteners in the context of gut health, what would we say?
I would say probably limit these things. But you don't need to avoid them in that if you wanted like a Diet Coke with your lunch on a Wednesday, that's fine. And I probably think that some may have a bigger impact on the gut than others, but we need that data before we can conclusively say we need to avoid them. Totally right. So same with emulsifiers and sweeteners. If you're eating a lot of these, you're probably eating a lot of ultra-processed foods, okay? And there's a lot of data, at least observational data, linking a high consumption of ultra-processed foods with gut health issues like inflammatory bowel disease and changes to the gut microbiome that are somewhat negative. So just have a think. If you're seeing a lot of these ingredients, these sweeteners, these emulsifiers on your foods that you're consuming daily, you might just want to reduce the level of ultra-processed foods that you're eating and replace it with some of those foods we spoke about, like the ones that are high in prebiotics, polyphenols, fermented foods. Yeah.
Yeah, or at least add them in
At least that
on top of what you're currently doing. Because,
Yeah.
I guess it's quite hard to avoid ultra-processed foods now, isn't it?
It is.
It's everywhere.
Yeah.
So let's move on then to common myths and misconceptions. And I think you perhaps have a unique view on this because you're working with patients on a daily basis, but you've also built an educational platform for yourself, the Mr. Gut Health, on TikTok and Instagram. Is it Mr. Gut Health on TikTok as well? And therefore, you probably get sent lots of content and see lots of content from other people who've got big profiles who basically are just producing content to appeal to their followers. And some of it might be a bit, what is it they say, clickbait type content. So what are some of the things that you see popping up that perhaps are just not very good?
There's quite a few, to be honest. I'd say one of the biggest myths is gluten intolerance. I think gluten intolerance is a myth, right? So you have wheat allergy, you have celiac disease, and then you have gluten intolerance or non-celiac gluten sensitivity, right? So wheat allergy affects only around 1% of the population. So to put that into perspective, 5% of the population are allergic to kiwis, right? But I'm not going to tell you to stop eating kiwis because I think they're another amazing food for gut health, right?
With the skin on.
I
eat the whole thing.
You can, but the studies of kiwis and constipation, they actually take the skin off. Yeah.
Is that not the best?
I think that's just because it's more appealable to people, right?
Yeah, people look at me like when I'm in the office, I'm just like shoveling it down. They're like, what is wrong with our boss? Like, why is he eating just
I think it depends on the kind of kiwi. Because sometimes they're a little bit furrier than others. The gold kiwis tend to have a smoother skin. I don't mind that. But the green ones...
for the green ones, man. Yeah, just straight in. Each to their own, yeah.
So then you have celiac disease, which again is similarly affects only around 1% of the population. So celiac disease is an autoimmune condition where the cells that line the small intestine, called villi, which are responsible for absorbing nutrients, they become inflamed and damaged in response to gluten ingestion. Okay? This leads to symptoms like diarrhea, abdominal pain, and bloating. And then you have gluten intolerance or non-celiac gluten sensitivity, right? Which is not celiac disease, so you don't get an autoimmune inflammatory response, but you still get symptoms from ingestion of gluten. Now, in several randomized controlled trials, in people who think they have gluten intolerance, when you give them a meal that contains gluten or placebo and they're blinded to that meal, they cannot distinguish between the two meals.
Based on symptoms?
Based on symptoms. In fact, both of the meals tend to cause a little bit of an increase in symptoms, and we call this a nocebo, which is where...
A nocebo?
A nocebo. So nocebo is where you get an increase in symptoms due to negative expectations around something that is otherwise harmless, right?
Interesting.
So there's kind of a psychological aspect to that. But when some of these studies also show that when you give these people fructans, so fructans are a fermentable carbohydrate, a FODMAP, which we've spoke about, when you give them fructans, they get much worse symptoms than the gluten or the placebo. So most people who think they have gluten intolerance actually have a fructan intolerance, okay? So fructans are also found in garlic and onions because they're a FODMAP that's abundant in nature. But other gluten-containing grains, so wheat, barley, they're high in fructans. So probably one of the reasons why people feel better for giving up wheat, or gluten, should I say, because it's in wheat and these other grains, is because of the fructans. And there's a little test you can do to see if this is you, right? You can get some sourdough, some proper sourdough that's made from wheat, because it still contains gluten, but it should contain virtually no fructans if it's proper sourdough, right? Not the stuff from the supermarket.
How do we know if it's proper? It's got bacon.
I mean, you go to the baker, they've got the good stuff.
I hear you.
Yeah,
I got it.
Yeah. So still contains gluten, virtually no fructans. And if you eat that and you're fine, then actually it's probably not a gluten intolerance, it's probably a fructan intolerance. So you don't need to give up bread, right? Because sourdough is amazing. And
it is.
Yeah.
It contains fibre as well, right?
Yeah, it contains fibre. Potentially contains some of these postbiotics, right? Because during the fermentation of the flour, these microbes are producing things, they're going to die. So they're not alive when you eat them, but you might get some of their benefits.
So that's the gluten element. What about dairy? 'Cause you mentioned yogurt is great. And I was thinking in my head, well, a lot of people cut out dairy. Is there a story there?
The next thing that people cut out after gluten, or sometimes they cut them both out at the same time, is gluten and dairy. Okay? Dairy, because apparently it's inflammatory to some wellness influencers. Actually, meta-analysis has showed that fermented dairy, right, so again, yogurt and kefir, is actually associated with a reduction in inflammation, a reduction in inflammatory markers, like CRP, okay? So
it's not inflammatory?
No, it's not inflammatory. But there are some people that do feel better for giving up dairy, right? And there's potentially a couple of reasons for that. One is a cow's milk allergy. So they're allergic to the proteins in cow's milk. But they can usually tolerate other animals' milk, like yogurt from sheep or yogurt from goats, okay? They might have an intolerance specifically to the A1 beta casein protein, which is really abundant in cows, less abundant in goats and sheep milk. But you can actually get cows that exclusively produce A2 beta casein, so they don't produce A1. So Jersey cows, for example, they produce exclusively A2 beta casein. So you can actually try A2 milk or Jersey cow milk to see if you can handle that.
Interesting.
All right. But then the third, more common reason is lactose intolerance, right? So lactose intolerance is where you don't produce enough of the enzyme lactase. So lactase is produced in the small intestine. And what that does is it breaks down the lactose sugar so you can absorb it. If you don't have lactase, then that sugar moves all the way through your gut to the colon.
There we go.
And it's fermented by the bacteria in the colon where there's loads, trillions of bacteria. So they feast on the lactose. They produce gases, which cause bloating, really bad flatulence, right? That's a classic symptom of lactose intolerance. And because it affects the osmotic gradient in the colon, you get diarrhea as well. Around 2/3 of the world's population have some degree of lactase deficiency. It's more common in African and Asian populations. And that might just be an evolutionary thing, right? Because probably in the northern hemisphere, we relied on dairy for a source of nutrients, whereas food is much more abundant there in terms of fruits and vegetables and other crops. But what a lot of people don't realise is that with lactase deficiency, lactose intolerances, they can still have dairy, okay? So there's some cheeses that contain virtually no lactose, like Parmesan, and any other aged cheese. So the longer the cheese is aged, the less lactose it has in it, because what those bacteria are doing during the fermentation process is they're breaking down the lactose outside of your body, so instead of inside your gut. So they're reducing the levels of that lactose.
Interesting.
So you've got Parmesan, you've got extra mature cheddar, for example, and then yogurt and kefir are naturally lower in lactose while they're not completely obsolete of lactose. They usually contain less than 5 grams per serving, all right? And studies have shown that most people with lactose intolerance can actually handle around 6 to 12 grams per serving.
So if someone's experiencing symptoms when they consume dairy, how do they kind of work through those 3 different pillars to see which one it is? Is there a specific test or?
Yeah, it's a good question. So what I would say first is to actually remove all dairy from your diet.
See what happens.
Yeah, see what happens. If you feel better, great. But you don't need to give it up because we have alluded to the potential health benefits of at least fermented dairy, like yogurt, kefir, and I would argue that cheese has health benefits as well.
Good.
Yeah,
that's very good. Cheese is good.
Yeah, especially live cheese, not the plastic cheese.
Yeah,
right? So I would remove it all, and then I would probably start with some cheese that contains virtually no lactose. So you could have some Parmesan or whatever, see if you're okay with that. Or you could try a lactose-free milk instead. So you can buy milk where the lactose has been removed, and you can have a cup of that. Don't eat anything else. See if you're okay. It's good.
There you go.
It's or again, if it might be one of these, it's a little bit less common, but if it was like the cow's milk allergy or the A1 beta casein, you could try something that isn't cow's milk. So you could have some buffalo mozzarella, or you could have, just a sheep or goat's yogurt.
It's all good stuff. You see, it's
And what I should say as well is there's actually clinical evidence to show that if you have lactose intolerance, the more yogurt, the more kefir you eat, the less tolerant you become to lactose. So you can build up a tolerance. You can build up lactose digestion.
Now, can I just push a little bit on that? Is there any merit in taking a similar approach to, for example, FODMAPs? Now we're talking blue sky thinking, right? So is it the case that if someone who has a sensitivity towards FODMAPs, if they just eat more and more and more FODMAPs, they eventually sort of get over their issue? Is that a thing?
I think some people, yes. If you do have an underlying condition like SIBO, then you're never going to get to that threshold. In fact, you're just going to get worse. Right. So if you've ruled out the SIBO
through working with people like yourselves.
Yeah. So just through a simple hydrogen and methane breath test is the easiest way to do it. And you're still struggling with FODMAPs, you should be able to build up a tolerance. There's actually studies in beans specifically because beans are very, gassy.
Well,
right?
Yeah. There's all sorts of songs.
Really good. Yeah. So beans are notorious for that.
Yeah.
But
why is that? Sorry,
they're just full of fermentable fibers, different ones, galacto-oligosaccharides, and so really good for you though.
Good for
I mean, if you watch the Blue Zone stuff show that beans are a massive part of some of the
fermented foods, right?
And fermented foods. So there's studies with beans that actually, if you gradually increase the amount of beans you eat every day, you become more tolerant, so you're not farting as much for want of a But who can do that?
Not the most technical term on the podcast, but it's all good.
I'm not sure if you want to be doing this whilst you're at work 9 till 5, right? If you're working from home, then it's fine, right? Just add a few extra beans to your beans on
just go for
breakfast. But I'm not sure the office will be happy with you trying to improve that.
Beans are one of my primary sources of fibre. All different types of beans.
Love it for fibre. Plant-based protein as well.
Yeah.
Super. Again, another great food.
Super.
But you could probably build up a tolerance to FODMAPs and other fibres
just
as well.
Before we go back to the myths and misconceptions and dairy, and by the way, that short bit there on dairy was just awesome. I know a lot of people are going to love to listen to that. I did. I've learned a lot from that. Why is, and this is maybe more of a philosophical question, but why do we not test for SIBO more in the NHS? Is it so actually, back a step again, is it an accepted diagnosis?
So, yes, it's a legitimate condition, right? But it's taken a while for it to become legitimate. It was actually first sort of not introduced, but the alternative wellness industry sort of cottoned onto it. And they said it was the cause of most people's IBS and stuff, right? And then doctors were like, I don't know what you're talking about.
But sometimes they are actually further ahead.
They're usually further ahead with a lot of other things as well, which is why we always think the truth lies somewhere in between this alternative and conventional medicine, right?
That's kind of fascinating, isn't it?
Yeah. So with SIBO, in the States, it's recognised. It's in the guidelines. It's got its own guidelines. It's in the IBS guidelines. In the UK, the BSG guidelines don't acknowledge it. In fact, they don't even recommend breath testing for lactose intolerance, which has a lot of evidence behind it. I mean, what would you rather do? Would you rather spend weeks trying to work out if you're intolerant to lactose, what your threshold is, or would you rather just do a quick test to determine whether you have it, right? Same with SIBO. It's not,
right?
Yeah. The main argument is you get a lot of false positive or false negative results with a SIBO breath test. Well, that's what their argument is. But my argument is, or at least in the UK, my argument is we have the data to show that you take the test, it predicts your response to the treatment. So if you have IBS-D and you take a SIBO breath test and it's positive to lactulose, okay, you are nearly 3 times more likely to respond to rifaximin than someone with IBS-D who tested negative. And that's really important, especially in the UK, because rifaximin isn't a licensed antibiotic. It's usually prescribed privately and it's going to cost you like £200-300. So you'd want to know if taking that medication, or even in the NHS, right, if we're going to give someone this expensive medication, are they going to respond to it or not?
Yep.
So I think there's still a long way to go in the UK, but a simple breath test that you can do at home to determine. So this is it with lactulose as well. It's a bit of in the UK, they argue you see a rise in gases on a SIBO breath test, right, with lactulose. And they argue that 90 minutes, where the rise should be before, is that lactulose still in the small intestine, or is it in the large intestine being fermented by the colonic microbiome? So you're getting a false positive result. But because we've got the cut-off of 90 minutes, which predicts a response to treatment, and either way, even if within 90 minutes it is actually being fermented by the colonic microbiome, the studies show that it's still helpful. So either it has this eubiotic effect. We actually think rifaximin it helps with like sensitivity as well in the gut. So a lot of in a post-infectious kind of irritable bowel syndrome where the infection's cleared, but the gut's now become more sensitive to what's moving through it. It seems to have benefit in that. So yeah, I think the UK have a long way to go, but the alternative wellness community, I mean, they were onto SIBO. Now there's these other. Have you heard of the theory euhemerism? It's a Greek mythology theory from Euhemerus, who was like a philosopher, who basically said that mythological heroes and mythological stories, right, were based on real historical events and figures, but over time they've just been exaggerated, right? And I think this is a little bit what the alternative wellness community are doing at the minute. So these holistic practitioners and stuff, they will take something used to be SIBO, but now even we know that's a legitimate condition, but now it's things like candida, which is yeast, and parasites. So they'll take that and make it look like it's the root cause of your problems. And then what will happen is someone will go to their conventional doctor and say, I've seen this online, I think I've got candida, I think I've got parasites, and the doctor will just shut them down.
Yeah, for sure.
Say it's nonsense. This is where the truth lies somewhere in between, right? So if you can get an overgrowth of bacteria in the small intestine, surely you can get an overgrowth of yeast.
For sure.
Yeah, right? We know you can get a yeast overgrowth in the esophagus, so you can get candida in the esophagus. You can get yeast infections, right? Absolutely. Of the genitals. So why not of the gut? And the only problem is it's very difficult to diagnose. We don't have this defined pathway like we do with SIBO, with all the testing. Traditionally, at least with candida and yeast, so candida is a type of yeast, but you can get other different types of yeast that overgrow in the gut. Traditionally, the only way of knowing if you have that is to actually do one of those upper endoscopy, take a sample, right, and grow that culture. So there's a group in the States, Satish Rao's group, which found that in people with unexplained tummy issues, but without any immune disorder, that 1 in 4 of them had SIFO, so small intestinal fungal overgrowth. So they actually had an overgrowth of fungi and yeast in the small intestine. But that's the only way to test for it. You can't do a stool test because even 1 in 2 healthy people have yeast in their mouth. It's the part of a normal microbiome, right? Absolutely. Yeah, and we've already spoke about how the stool microbiome doesn't reflect the small intestinal microbiome. Some of the wellness practitioners say you can do this D-arabinitol metabolite test. So it's a sugar alcohol that not all species of candida, but some of the pathogenic ones produce. I'm not seeing any sort of outcome data to show that, but that's one avenue. We're trying to find ways of looking for it at the minute.
How do you get rid of it if you find it?
Well, that's a good question. So we use antibiotics to clear SIBO. You probably think antifungals to clear yeast, right? There's just not a lot of data on that. I would imagine that antifungals are, I don't want to say safe, but they're a little bit less precarious than antibiotics because most of the microbiome is bacteria, right? So if antifungals just target the yeast, you're probably not affecting that as much as you would with an antibiotic.
Almost certainly.
Yeah.
But that's a future avenue, right?
That's a future avenue that we want to look down. And then the next is the parasites, okay? So parasites were all the rage. A parasite cleanse was all the rage on TikTok last year. Okay.
Oh, really?
There was a point where my feed was just full of parasite cleanses and people, wellness influencers selling a parasite cleanse, right? So you buy their 14-day parasite cleanse, okay? But here's the thing, right? So there's different kinds of parasites. You've got unicellular, so single-cell parasites like your Giardia and your Cryptosporidium, okay? And then you've got your multicellular parasites, your helminths, your worms. So they're selling this parasite cleanse, 14 days, and they're posting pictures, probably not their pictures, right? Ones they've taken off the internet of someone who's just evacuated a load of worms or what looks like worms at least, right?
Wow.
Which is
This is what they're showing?
this is what they're showing. But to treat, you'll know you've got a worm infection usually because you'll see them in your stool. To treat a worm infection, all you need to do is take literally one tablet.
Yeah.
One tablet or a 14-day parasite cleanse with unregulated herbs in that probably taste like shit, right?
Yeah.
Got to take it 3 times a day.
Yeah.
Don't even know if it works. It's a no-brainer.
So the cleanse was some sort of herbal proprietary blend.
Yeah. Obviously unregulated. God knows if they were contaminated with heavy metals and what. But it was all the rage on TikTok in 2023.
And just as an aside for the listener, if you see proprietary blend on an OTC supplement,
red flag.
Big red flag. Huge red flag. I did
Yeah.
a solo podcast episode on this a couple of weeks ago. Do not go near that because it could literally be anything.
Yeah.
Anything, right?
Huge red flag.
So what other TikTok things are all the rage at the moment? And
at the minute, it's more just people in grocery stores with the tops off shouting at things, and it's the emulsifiers.
So it's not just you. It's not just you doing that.
No, I don't have. I keep my top on, and it's all positive.
Oh, some people have their top off.
Yeah, I don't. You'll probably know him. He promotes I
don't have TikTok.
He promotes a carnivore style diet. He says vegetables are bad for you.
Is this? It can't be. It's not that guy. What's his name? Who got
Carnivore MD? I think is his.
Oh no, I was thinking of this guy called Liver King.
No. Well, it's real. Like if you look into the background, he has They both have shares in the same company.
I thought the Liver King guy was exposed as
he
being
was
like
exposed.
a massive
He was
fraud.
exposed.
In the context of he was taking like, it was actually hilarious. He was like
thousands of pounds worth.
He was literally like, I'm natural.
Yeah.
He was like, it's all bull testicles and weights. And then some guy sent, or some person, not some guy, sent in his correspondence with a doctor. And I think in sort of like totality, he was spending like tens of thousands of pounds a month on growth hormone, insulin, steroids. You know, and it's like, whoa, that's what you've got to do to look like him. So comedy. I couldn't. Well, I think. I mean, we all knew, right?
Yeah, we all knew, but it was not. Not everyone does.
Fascinating.
So,
fascinating. Yeah, cool.
Yeah. So it tends to be more that kind of thing now, but. Sort of going back to the parasites, there are obviously these other parasites that we can't pick up as well, like the Giardia and the Cryptosporidium. Yeah, so they're not that much bigger than bacteria. And what happens is if you get an infection from these, an acute infection, it normally presents like gastroenteritis or food poisoning. So you'll have diarrhea, maybe vomiting. It usually settles down after a few days. You go back to normal, right? If it doesn't settle down, you go to the doctors. Even then, they don't necessarily test for it. They probably just ask you, have you travelled to this location? Have you eaten something a bit, So they'll just prescribe you some antibiotics or anti-parasitic medications empirically. So you don't know if you've had that initial infection.
Yeah.
Okay. But what we do know is that an acute infection from Giardia, Crypto, Blastocystis increases your risk of developing long-term gut health issues like post-infectious irritable bowel syndrome. In fact, gastroenteritis, whether it's caused by parasites, bacteria, or viruses, is the single biggest risk factor for ruining your gut health, basically. All right. So I would argue the best thing you can do is try not to get food poisoning, right? And depending on the kind of bug that infects you, depends on how much more likely you are to develop long-term gut health issues.
Oh, that's fascinating.
So arguably the worst based on the evidence is Campylobacter. So people who get infected by Campylobacter, 1 in 5 of them will still be having tummy issues 12 months later. And 1 in 5 is less than rolling the dice. So imagine you got food poisoning and you roll the dice to see whether in 12 months' time you're still going to be having diarrhea and tummy pain. Yeah, so
that leads me nicely into what do people need to do to avoid Campylobacter and the others? Presumably it's Salmonella.
Yeah, so Salmonella, the classic bacterial, E. coli, even though there's the good ones, right? The probiotic ones.
I hear you.
Yeah.
What are the worst culprits?
So, yeah, there's Campylobacter, Salmonella, E. coli, those kind of things. I think the main thing is food hygiene, right? Okay? So make sure you're cooking your food properly. None of this raw milk. That's a big craze actually on TikTok at the minute. Have you seen that? Unpasteurized raw milk.
Seen that? Yep.
Straight from the cow.
Yep. I've seen a lot of
So
that.
I don't deny that it probably has some health benefits because
Sure.
we've already spoke about the health benefits of yogurt and kefir. But I urge you, please do not try this, right? Because it's now the number one source of foodborne illness, at least in the States. I think it's a little bit more difficult to get hold of over
A
in.
lot of athletes take the raw milk, right?
Yeah. I think Erling Haaland does. Yeah.
I was just about to say.
I was like, mate, you're one batch away from ruining your career, right? Yeah. So.
Oh, it's so funny.
No, I tend to avoid like other raw foods as well. Like I'm a bit, sushi. I think if I went
Don't say this to me. I'm going for a 12-course sushi tasting menu on New Year's Eve.
I'm so sorry. But no. If you go into the like proper sushi place, right? I'm talking not like the stuff you get from the supermarkets. Proper sushi place, I would have that. It's really tightly controlled.
And if it's got that yellow sticker on it that says it's reduced,
do not take.
Do not eat. Do not roll the dice.
It might sound like a good idea, but it's not. Yeah.
I got you.
So yeah, raw food hygiene, raw foods. Another thing is traveling. So a lot of bugs are picked up when traveling. So traveling to South Asia is the biggest risk factor for developing post-infectious IBS. And they think it's because there's quite a high prevalence of like Campylobacter there.
Interesting.
So being careful when you go away, maybe taking a probiotic before you go to reduce the risk of travellers' diarrhoea, taking an intestinal absorbent with you, like Enterus gel. So they work by, if unfortunately you do get sick, or you can take it prophylactically, like Imodium stops you from going to the toilet, right? Stops the diarrhea, but these intestinal absorbents actually stop the diarrhea and remove some of the bacteria and toxins from the gut as well. So they're really good to have on hand.
Interesting.
Yeah.
So take some Enterus gel with you.
Enterus gel has been studied in irritable bowel syndrome with diarrhea.
Can you just buy Enterus gel off the shelf, or do you have to order it from?
Yeah, you can buy it from most like Boots and Holland & Barrett and stuff, and online. So we was part of that clinical trial. Actually, it was a huge multi-centre study in IBSD. And there was we were one of the sites for it, and really positive outcomes for diarrhea and other IBS symptoms. So if you have IBSD, I also think it's something worth trying. So I take something like that, hand sanitizer, because you need to be sanitising all the time before you have something to eat, especially before you put your fingers in your mouth, when you handle cash, that kind of thing. So yeah, travelling is another big one, and then food hygiene. Yeah.
Thank you for all of that. And again, you've got lots of amazing content on your social media profiles about this. And I think also something as well about dairy. At one point, you had a very funny video of someone putting Parmesan on your pasta.
Yeah. Well, next time you go and they offer you Parmesan, if you're lactose intolerant, you don't have to say no, right?
No worries. Yeah. Only if you're just sensitive to dairy more generally.
Yeah.
Or Parmesan's from cows, so
the cow's milk.
Yeah. No, thank you.
Yeah, test at home before you go.
So what's your thoughts on home microbiome testing?
I think if you've got money and you're interested, then by all means do it, just to see how diverse your microbiome is. But clinically, it's not going to give you anything useful, right? It's not going to really dictate what you're going to do, other than if your microbiome isn't that diverse, you should probably try incorporating some more of these prebiotics and polyphenols and those things that we've spoken about. I think it's mostly a research tool at the moment. And as I've said, I think it's probably more the small bowel, and the small bowel microbiome, I think, is going to be where it's at, right? Because
interesting.
This is, again, going back to the group in the States, what they've shown is that at least in people with IBS and small intestinal bacterial overgrowth, there tends to be a certain cluster of microbes that are related to these symptoms, like Klebsiella and like E. coli. So that might be interesting to know. But clinically, I don't think you're going to get that much use out of one. So if you've got loads of money for Christmas and you really are desperate to know what's in there, be my guest. But otherwise, don't waste your money. Go and buy yourself something nice.
That's a fascinating response. It's very similar to one that I got last week from one professor from University of Glasgow and a consultant paediatric gastroenterologist from Dundee. And I also asked Alan Walker, I don't know if you know him, Dr. Alan Walker, he's a microbiologist at the Rowett, and they all kind of said the same thing, which was it might be quite cool to see what's in your gut.
Yeah.
from a kind of just general self-interest perspective, but one of the things they were describing as being a real challenge is that some of their patients are bringing in these reports, which you potentially get as well, right? Yeah. And you know, you're an expert in this, that the company you're working with is an expert. There's not really much you can do with it, is there?
No.
And patients think they've done a good thing and coming in and with this profile going, yep, what's next?
There's one in particular that I think is over £300 for the test. And it comes back with all this traffic light system of you've got a lot of this one or you've not got enough of this one. But yeah, clinically it doesn't really mean anything. And I think I've seen in the data as well, like depending on what, like the stool that you take in the morning or the evening or where you take the stool sample from can actually change the abundance of what's seen in that sample, right? So,
right.
Yeah.
So it's a general self-interest thing.
Yeah. So what I'd really like to do is probably, if you could afford to, send 2 off at once and see what they come back. And if they come back totally different.
I was going to do that.
Yeah.
I was going to send it to like 5 or maybe even more and see what happens.
Yeah.
So I'll get you in on that
Yeah.
if I decide to do that.
Yeah.
We talked about gluten and dairy. Any other myths and misconceptions that kind of stand out? TikTok trends, social media trends that people should be aware of?
I just think be careful when someone makes it sound, I don't want to say too good to be true, but makes it sound like they've got the answer to all your problems, because they're usually selling something down the line, right? And I'm going back to parasite cleanses here, but they'll make it seem like it's the root cause of your problem, and then they're selling a parasite cleanse.
Right.
Or they'll say Candida is your problem, they're selling a Candida cleanse. It's like a multi-level marketing scheme that a lot of these wellness influencers do, and it's basically just, they're not interested in your health, they're just interested in their own financial gain. Right?
What about these colonic irrigations?
So colonics are, I don't know, it's not something I would risk. I mean, the risk of perforation
is a real
although
risk.
it's pretty low, it's a real risk,
yeah.
Right? And there's no evidence to show that really a colonic will benefit you unless you have refractory constipation, and usually it's if you have a neurological cause of constipation, right? Then an enema can help with the feeling of incomplete emptying. So once you've been to the toilet, sometimes you feel like there's stuff there. An enema at home by yourself, it outweighs the risk, in my opinion. For any other reason, I would not do a colonic, right? I don't think there's probably that any real benefit to it. But what is interesting is what we hear from some people is that when they go for their colonoscopy, right? So when they take a load of laxatives and have a good flush out, they feel better. So for a few days at least, right? Because usually what happens, I think, is probably clearing out all those microbes
and toxins.
So that might I don't know, maybe an area to look into, but I'm not recommending people go away and take a lot of laxatives.
No.
No, definitely
not. That could be very dangerous.
Yeah, definitely. But I just think it's quite interesting.
It is.
Yeah, so colonics, I don't think it's worth the risk, in my opinion.
So now, coming to the end of our conversation, could you maybe look into the future a little bit and give some perspectives around how do you see this whole field kind of progressing? And what does success look like for you, for the field more generally and the work that you're doing?
So it sounds a bit cliche, but a bit more personalised, right?
Mm-hmm.
So I always go back to the example of IBSD and all these different potential organic causes that manifest, right? I think what we need to do is have a defined set. I mean, it's a bit biased from me as a physiologist because we love to test, but an algorithm of the tests that you do
mm-hmm.
that are actually evidence-based and, not like a stool microbiome test, which isn't going to give you any information usefully, but the right tests, then the right treatments, right? And then also following up as well. I think what happens a lot is we always capture the people that have done the test, they've had the treatment, but then they come back. We don't always get the people that do well. And what we want to know is why these people did well and these other ones didn't, right? So
I'm with you.
I would like to have a bit more, follow up, and I think that can help us to really figure out what works and what doesn't.
What are the determinants of success, essentially, right?
Yeah,
and
exactly.
Teasing that out. Good. So before we finish, then, should we try and recap?
Yeah,
We've talked about so much.
A lot.
It's going to be really hard. It's been an amazing, cracking episode. So thank you. Why don't we maybe just say a few words about some of the big buckets and themes we've talked about today, which might be quite challenging, but we can give it a go, right?
Yeah.
So let's start with IBS then. So you talked a little bit about how it was once thought of as a disease of the gut-brain.
Yeah. Still, the gut-brain definitely plays a role, but there are potential organic causes of irritable bowel syndrome that have their own specific treatments where you can then, I don't want to say be free of IBS, but you can manage it really well.
And you've got tests.
And there's tests
to help sort of, hopefully, if you've got some of these symptoms, diagnose you under one of those buckets, which means you can get the correct treatment, which means hopefully you can be IBS free.
Yeah.
Prebiotics. Let's try and summarize that. So go for it.
So there's fermentable prebiotics that might worsen some of your tummy symptoms, especially if you have a sensitive stomach. There's the more easy to digest prebiotics that you might want to try, and I think that if you're a healthy person, you might want to supplement a prebiotic. Again, you can go to Tummy MOT and see which ones have evidence in healthy volunteers, and then just to get a diverse range of colourful plants, fibre if you can tolerate it right, and then I would argue that fermented foods also contain prebiotics as well. So
we also spoke a little bit about beans and how they can produce flatulence.
Yeah.
So maybe one of the other things to add in is if you're going to add in a prebiotic, don't go too high too fast.
Yeah, exactly. So if most of the reputable prebiotics will actually say on them to start at maybe half a dose.
There we go.
For like a week, and then you can increase it to either 3/4 or a full dose. Yeah.
Greek yogurt is awesome.
Yeah. Yogurt and kefir.
Polyphenols, also awesome.
Awesome, yeah.
Food for your microbiome.
Yeah.
Get them in colours, that's great. Emulsifiers, some potentially okay.
Some okay, some less so. Like to see more data. Just remember, if you're seeing a lot of these ingredients on the daily, you might be eating too many of them, and just to reduce your consumption of the ultra-processed food.
And seemingly the natural ones, i.e. if it's been made by God rather than man,
yeah.
if I can say that, yeah, might be better for you. Same story with sweeteners.
Yeah, yeah.
In terms of what is gut health, there's no defined definition, right? But mainly it's being able to tolerate kind of whatever you want to eat, not rush into the toilet and not having GI symptoms.
Yeah.
Kind of work there?
Yeah, or at least GI symptoms that you can put up with, right? Because not everyone's going to get that 100% resolution. What you want to be achieving is 70, 80. That's what I always say to people. You might not get 100%.
Love that.
Have 70, 80% as the goal, and the quality of life.
Love that.
Yeah.
Small bowel has had less research than the large bowel because it's harder to study, but in your opinion is potentially the future of the field.
Yeah.
At-home microbiome testing, if you've got the money and if you're interested, yes. We've got a lot in there on dairy. So basically, not all dairy is bad. Mm-hmm. And you can potentially bucket your intolerance into 3 defined groups.
Yeah.
So there's an intolerance to cow's milk.
Yeah.
There is a deficiency in lactase.
Yeah.
And let me just try and get this one. Something to do with A1 and A2
That's
proteins.
It, yeah. The casein, the A1 casein.
A1 and A2 caseins. Whew. What an amazing episode. And I'm sure I've missed stuff in the recap. I just wanted to say thanks.
No, thanks
You've
for having
travelled
me.
to come in. I really appreciate that. It's between Christmas and New Year. Most people are winding down. Here we are speaking about gut health for the best part of 2 hours. Thanks for all the work that you're doing. Please visit tummymot.com. Mm-hmm. Please visit Mr. Gut Health on your social media platforms. And speaking on behalf of Antibiotics, really excited to collaborate with you and the guys at the Functional Gut Clinic.
Likewise.
Next year.
Yeah.
So thank you so much.
Well, thanks for having me.
Pleasure.